In my role in the Department of Gynecology, I began to see large volumes of women with a diagnosis of provoked vestibulodynia, which, as I'm sure you all know in this audience, probably affects somewhere around 15% of the reproductive age population of women. Women will describe the pain at the vaginal opening as cutting, tearing, burning, stinging. Many of these women will report dysuria or pain with urination, hours, in some cases days, following vaginal contact. For many of these women, for most of these women, in fact, it has a profound impact on their relationships, on their quality of life. They avoid sexual penetration, as well as many other aspects of sexual contact and intimacy, for that matter. It's also associated with a lot of stress, distress, anxiety, mood symptoms, and can be quite a debilitating condition. In fact, there's some health economic data coming out of the United States that find the annual burden of provoked vestibulodynia, once you take into account all the direct costs like medical bills, cost for medications, doctor's visits, etc., as well as indirect costs, time lost from work, secondary disabilities, etc., is somewhere in the order of $31 to $72 billion annually. So quite a major burden of illness with provoked vestibulodynia. And what do we know about provoked vestibulodynia? Well, one theory is that, like other chronic pain syndromes like irritable bowel syndrome, fibromyalgia, etc., that there is a role for central sensitization. In other words, the pain centers in the brains are misfiring. And this is quite a different theoretical view than what used to be thought. It used to be thought that this was a dysfunction that was located really in the pain receptors of the vulvar vestibule itself. And as a result, when you look at early treatments for provoked vestibulodynia, they tended to involve more local topical agents like steroids, like antihistamine agents like cromolyn, etc. And as I'll show you in just a moment, there's not a great deal of evidence for the efficacy. And so researchers have really over the last decade sought to understand, well, what else is perpetuating this pain, especially since on physical exam, there's really no evidence of any tissue damage in these women. In fact, the tissue at the vulvar vestibule looks entirely normal. So researchers started to look kind of higher up in the system, and there's much, much more evidence of central involvement. In other words, brain coordination, brain involvement. And one of the things you can see in this image on your slide here is the inputs into the spinal cord, not only from the vulvar vestibule, but from neighboring structures like the pelvic floor muscles, which are found to be chronically tense in women with provoked genital pain, from the bowel and bladder. And certainly there's evidence that women with provoked vestibulodynia have a much higher incidence of bowel and bladder difficulties like interstitial cystitis, irritable bowel syndrome, chronic constipation, etc., etc. And so there's much more input kind of going into these sensory nodes in the spinal cord. But ultimately, that much of that activity is orchestrated higher up in the brain. Okay, and so when we talk about provoked vestibulodynia, it really is a brain event. Now that can be a really difficult concept to swallow for women who may have been told, in fact, often are told by their physicians that, well, there's no evidence on the exam, your tissues look entirely normal, this must be in your head, go home and have a glass of wine. And so knowing about knowing the sensitivity that these women may have about messages around this may be their fault, this is psychological, this is a result of some kind of sexual inhibition on their part that's under their control. We need to tread very, very lightly when we're talking about PVD as largely a brain event.